And look, on behalf of the Distilled Spirits Council and responsibility.org, I have the privilege of leading both organizations. And I'm a son of a veteran, a brother of a veteran, and part of a family with a long lineage of veterans. And for myself, first and foremost, thank everybody for joining. We have an esteemed panel, and we recognize that our nation's heroes every day have to grapple with challenges associated with PTSD, and at times challenges associated with substance abuse as well. So responsibility.org is committed to try to bring awareness to these issues that our nation's heroes struggle with, and bring forward programs to help our nation's heroes. So when I talk about nation's heroes, these veterans risk their lives, their families are impacted, and all of the above. So let me turn it over to my friend and a nation's hero himself, retired Major General Arnold Panaro, who carries a Purple Heart and is a leader in his own right on supporting veterans and supporting our military. So General Panaro, over to you, sir, and thank you for being with us.
Well, thank you, Chris, and it's a privilege to join all of my distinguished colleagues, to be able to talk to our veterans and other experts on the line today. I want to thank Chris and responsibility.org for all they do in this area with our veterans and other activities. November 10th and November 11th every year are very special days for me, for our veterans. November 10th is the birthday of the United States Marine Corps, and as a Marine, we pause no matter where we are in the world to basically commemorate our birthday, whether it was when I was a second lieutenant in the Quai San Mountains in Vietnam, or wherever we are today commemorating the Marine Corps birthday. November 11th, Veterans Day, is also a very special day because we commemorate and thank those that have served our country. People like my father, who served with Patton's Army in World War II. All my uncles on my mother's side and my father's side served. My oldest son, Joe, served in the Second Iraq War as a Marine. My youngest son, Dan, is currently serving as a captain in the Army Reserve. But November 11th also is a very poignant day for me because my older brother, Anthony, a Vietnam era veteran, got what we now know as post-traumatic stress. No one knew what it was then. No one knew how to treat it. The Veterans Administration had no idea how to deal with it. The Vietnam veteran that had it was called a malingerer. And on November 10th, 1972, my brother Anthony had a meeting with the Veterans Administration where those experts told my brother that he was going to be 100% disabled for the rest of his life and there was no hope. On November 11th, 1972, my brother Anthony, a Vietnam veteran with PTSD, went out and bought a gun and committed suicide. So I remember this day personally, and I wish the help that we're going to talk to you about today from our experts that are on the phone and the programs that we have today. I only wish that those programs were available to the Vietnam veteran of yore, like my brother Anthony and so many others. The other issue is, I'm told, and I defer to our experts, we're losing 17 veterans every day to suicide. And so we're going to talk to you today about what we can do, because one is way too many. And frankly, these are preventable. They're things that we can all do to try to prevent that. So with that, let's go to our next slide and talk about a little bit what some of the causative factors are. Alcohol, and of course, that's one of the responsibilities of responsibility.org. Alcohol disorders basically create a lot of the issues we're going to talk about today. 10 to 20% of patients seen in primary care hospital settings have this kind of alcohol disorder. And how can we basically, with some of our experts that'll talk to you, but also some that are on the call with clinicians and doctors, nurses, and others with expertise in this area, our veteran leaders and veterans groups you'll hear from. How do we increase screening and assessment among physicians and access to treatment, but not limited to medication-assisted treatment? So that's one of the things we want to cover today. Next slide, please. And again, we've talked about this. It is one of the most prevalent forms of substance abuse in our military. And the statistics we have are between 37 and 50% of Afghanistan and Iraq war veterans are diagnosed with some form of mental health condition. And again, I defer to our experts on that. But it just breaks your heart when you see these people talk about how it's affected their families. And there are a lot of programs out there. But again, I personally don't think, and I know our military leaders in uniform, I think back to when General Jim Amos and Renee Bardolph, who's on the call, worked in these areas in the Pentagon. He basically, one of his top priorities as commandant was, how do I combat the suicide? How do I combat the traumatic brain injuries? The Army Vice, same thing. Our leaders have really worked at this, but frankly, we've not made the kind of progress we need to. And so a lot of this, basically, these disorders, such as PTSD and substance abuse, and the trauma, like we said, are on the rise. And frankly, we owe it to our veterans to do a better job of helping them. Next slide, please. And here's another one that just talks about the prevalence of the co-occurring disorders. There are people you're going to hear from in a minute that are far more expert than I. 1 out of 3 veterans seeking treatment for PTS has a substance use disorder, and 1 out of 10 Iraq and Afghanistan veterans. And by the way, we have 18 million veterans today, and our experts from the veterans organizations can talk about that. They're in direct touch with these individuals every day. Most of them have not served long enough to retire from active duty, and they're out in our communities, and they need our help, and they deserve our help. And again, we're in a better position than they were in 1972, but we've got a long way to go. Next slide, please. Now I want to introduce one of our true experts. And again, we've got several that are going to be on today. Dr. Wesley Clark, the Dean's Executive Professor of Public Health at Santa Clara University, a fellow colleague on the responsibility.org board. His curriculum vitae is so long that we'd be here all day. But let me just say, this is an expert's expert, and we are so privileged to have Dr. Clark speaking to us today. Wesley, over to you. Dr. Clark, you need to unmute.
Thank you, General. I want to acknowledge the importance of this discussion. As someone who has treated a number of veterans when I was a psychiatrist working at the San Francisco VA, these themes that we're talking about today are important themes. I want to start off with the focus on the issue of alcohol. Next slide, please. As you can see from this chart, and just focus on the 2019 bar, we can see that 65% of our younger veterans have a alcohol use pattern in the past year, of the past month rather, and then those 26 and older, it's at 57%. So alcohol use is common among our veterans. Next slide, please. And then you go from alcohol use to the issue of an alcohol use disorder. And when we look at past year alcohol use disorder, we see again among our younger veterans 18 to 25 that some 26,000 meet criteria for an alcohol use disorder. And then we're looking at veterans 26 and older, it drops down to 5%, but that's over 1 million individuals who meet criteria. Next slide. As the General was pointing out, we deal with a combination, not just of mental illness, not just with alcohol. We also have the issue of illicit drugs as people try to cope. So in 2019, an estimated 3.9 million veterans had a mental illness and or a substance use disorder. And this was an increase of 6.5% over 2018. And this is composed of increases in both substance use disorder and mental illness. Next slide, please. The end of the 20-year war in Afghanistan has implications for veterans' health. The VA and DOD and others estimate that there are almost 1 million US Afghanistan war veterans, as you can see from this number. There have been almost 21,000 members of Afghanistan US armed forces who have been injured, and 2,455 US service members who were killed in Afghanistan. This situation clearly poses an increased risk for alcohol and drugs, and something that we need to keep in mind, because if we are dealing with PTSD and depression, then we also have an increased risk for isolation and suicidal ideation. Next slide, please. So we have to think, of course, beyond Afghanistan, and the VA estimates that there are 1.9 million post-9/11 veterans who are already enrolled in healthcare in its system, and almost 16% of all veterans who deployed to Afghanistan or Iraq screen positive for PTSD. And on the other hand, an estimated 11% of non-treatment seeking veterans have PTSD or depression. So we have to be concerned about the non-treatment seeking veteran as well as the treatment seeking veteran. And the VA anticipates that there will be an increase in veterans with depression, with PTSD, with suicide, and of course, alcohol use disorder. And it behooves us to, next slide, in our effort to provide care for our veterans, the VA recognizes that it has an obligation. It's the largest integrated healthcare system in the United States by its own account. It provides care in 1,293 healthcare facilities across the United States. Over 9 million veterans are enrolled in a VA healthcare program. And the VA is also the largest provider of substance use disorder treatment in the United States. And it offers patients suffering from substance use disorder, serious mental illness, a full range of services, including psychopharmacology and other services. Next slide. As you can see from this slide, that full range of services covers most of the behavioral health issues that we're talking about. But it's meaningless if we can't engage the veteran, if we can't identify the veteran in need before more drastic actions happen, as the general spoke of in terms of his brother. The key issue is that we have those services available, but we have to help the veteran understand what's going on with them when they're having difficulties in the civilian environment. Next slide. And this then introduces us to this new resource, a computerized assessment and referral system to help break the cycle of recidivism. And now I will hear from Dr. Livingston after my presentation. There are other screening tools, but this particular screening tool is useful to help address the needs of veterans. Next slide. In the community, especially, whether they're linked with the DUI court or any other clinical situation, civilian situation with practitioners who are outside of the VA. As Judge Robert Echando points out, the CARS system is a tool that's user-friendly and identifies substance use disorders and an array of mental health issues. And by the time you present to a criminal court or DUI, like a DUI court or a drug court, you've already started having problems that have come to the attention of the public. And what we don't want to do is to sacrifice our veterans when we should be trying to find resources to help them. So as Judge Echando points out, screening determines whether the participant is at high risk for recidivism and in need of treatment. So this is a vital service, and the court realizes that it needs it, and I believe that community-based organizations, peer-based organizations, veteran service organizations are in an ideal situation to help the veteran understand that care is needed and available. The VA can't help if people are not able to come to the VA because they don't recognize that they're in need of care. Next slide. This is what the CARS tool offers. If you take a look at the slide, you can see that a risk and needs assessment. It's a screener, an assessment tool. It gives immediate diagnostic information for up to 15 major psychiatric disorders. It allows treatment referrals tailored to an individual's needs and zip code. There's also a Spanish version of the tool, of the screening instrument. It's user-friendly, it's free to download, and can be used as an open source software package. It's been validated for use with a DUI offender population, and the screening itself takes 15 to 40 minutes, depending upon the veteran. It allows the veteran to articulate what's going on with him or her in that situation. And then if a further assessment is warranted, that takes 1 to 2 hours. But the most important thing, it allows the veteran to interact with the various questions and in the assessment situation with the assessor. Next slide, please. So we can identify mental health issues that influence hazardous alcohol use. The CARS is adapted from a composite international diagnostic interview, which is well recognized as an important diagnostic tool, and it's modified to the DSM-5. For those who are aware of the DSM-5, it is the Diagnosis and Statistical Manual that's promulgated by the American Psychiatric Association, and it can be used and the CARS can be used with non-clinicians and allows peer support specialists to participate in the assessment process. And we find that many veterans really relate to peers more than they do professionals initially. It is the peer support person who can help facilitate the screening. This is not a traditional risk needs assessment. It can facilitate identifying mental health needs and facilitate treatment and referral. And that's the important thing. It isn't just saying you have a problem. It is saying, look, I think you have a problem and there are solutions that you can use. You're not doomed to have this problem eternally. CARS comes in 3 versions: the full diagnostic version, the screener for mental health risk areas, a screener in Spanish. Next slide, please. These are some of the mental health conditions that are assessed in CARS. And as you can see, that's fairly comprehensive. It deals with these complex issues from PTSD, from alcohol, to DUI, to drug use, to people who have other problems in terms of anxiety disorder, psychosis, obsessive compulsive disorder, and of course, things like depression and suicidality. Next slide, please. The report would look like this, and we're giving you in this slide and the next couple of slides an example of a fictional veteran named Arthur who screened positive for a number of disorders, and the definitions are given for each disorder. So in this case, Arthur has what appears to be a panic disorder and possibly a generalized anxiety disorder, and the screen identifies some of the symptoms associated with both the panic disorder and then some evidence that Arthur might have a generalized anxiety disorder. Next slide. This slide is focuses on the alcohol use disorder. And it's an important thing to look at why we believe in the screen that he might have an alcohol use disorder. Remember, this is screening. And remember, the veteran is generally presenting with problems in his or her life. So it's not like you just randomly chose a veteran and say, you have problems. You've got a veteran who's struggling with the question of whether I have a problem or not. It's a version of motivational interviewing using the screening tool to help facilitate that. Next slide, please.
Hey, Dr. Clark, quick question for you on that. What do you think can be done to increase screening and assessment among America's physicians, and where can medication-assisted treatment fit more into the process of helping veterans access treatment in addition to the more treatment methods? And of course, you spent your life working this. You worked at the VA. You were counsel in the United States Senate to the Health Committee. You and I were served in the Senate as staffers at the same time. What can the people out there, what more can they do to help in this area in terms of the screening and assessment?
Remember, when people present, the most important thing is to have a tool to allow you to do that. People say, well, I don't know what questions to ask. I'm uncomfortable asking these questions. The car screening tool is one of the few screening tools that will allow you to do that. And people need to find time. We owe our veterans the time to ask about what's going on, looking at their history, helping them decide whether they need follow-up care, and helping to facilitate that follow-up care. Dr. Livingston will talk further about the tools that they use in the VA system. The key issue is that community providers and peer providers need to have a tool that gives them reliable information. So that's what we can do. When I was the director of the Center for Substance Abuse Treatment, we promoted screening and brief intervention as a clinical strategy for primary care. And this is particularly applicable when it comes to alcohol and other substances of misuse. In fact, the US Preventive Task Force recommends screening for alcohol. So again, the veteran is generally presenting for some problem that might be tied to substance use. And so the primary care environment, upon identifying that this person has had military experience or combat experience, that we should always explore a little further, not to make the veteran feel victimized or stigmatized, but to recognize that the veteran may be having some issues.
Thank you. Terrific advice and insights. And Dr. Livingston has been nodding his head yes.
Yes. Okay, I'm going to get to Dr. Livingston shortly. I just want to make sure that we see that a risk report can be generated from the CARS. And this is an example. In the next slide, please. Next slide is a blow up so you can see it more clearly. And you can see both the narrative, which talks about Arthur, our fictional veteran, and so that we can see on what we base some of these screening conclusions. Next slide, please. The risk report also focuses on treatment, and it shows whether the fictional veteran Arthur has had any treatment for any of the conditions that we've screened for. Next slide, please. And then we're dealing with the issue of, okay, I have issues. What do I do with them? And this is the resource locator. We can identify services within the community. Ideally, you want the veteran to go to a facility that has experience in dealing with veterans and their experience. The military experience is a unique experience, as the general has suggested from his own family history, and that unique experience is often not duplicated well in the community. Nevertheless, some veterans are reluctant to present to the VA, and this is where peer specialists and community providers can be of assistance to the veteran by using a resource locator, keeping in mind that the VA is there to offer services, and that if the community provider is aware of the VA, that they can help steer the veteran to the VA. But if the veteran is unwilling to go to the VA, we can help them identify what resources exist in the community. Therefore, we provide, shall we say, pincer movement. You can go to the VA, you can go to the community, and we're going to try to help you deal with whatever is going on in your life. Next slide, please. Who should use the CARS? It can be used by clinicians and non-clinicians. It can be self-administered or interviewer administered, and it can be used in a variety of settings, including courts, probation departments, treatment providers, primary care physicians, and emergency departments. It can be downloaded free at the website you see there, and there's a contact information for Chris' contact so that you can learn more about CARS or to receive free training. I think when the price is right, it's free. And the availability allows you, wherever you are, in whatever context, to help our veterans, especially as the general pointed out, we're talking about the birth of the Marines, and tomorrow we talk about Veterans Day. We need to be able to address this clinical issue, both alcohol and mental health issues, where we find our veterans. And sometimes the beauty of screening is the veteran does not have a problem. They may be worried about one. And then using motivational interviewing, we can reassure the veterans that things are okay. You should be mindful, you should watch, and you don't have a problem at this point in time. So let's keep working on keeping yourself safe. And with that, I'll turn it over to my colleague, Nick Livingston.
Well, Dr. Clark, thank you again. And now another expert we're going to hear from, Dr. Nick Livingston, is a research psychologist in the National Center for PTSD, Behavioral Science Division, and an assistant professor in the Department of Psychiatry at Boston University School of Medicine. He maintains a number of active lines of research to include studies on the co-occurrence of trauma, PTSD, and substance use disorder, development and evaluation of mobile and web-based interventions for substance use and PTSD, examinations of mental health disparities, healthcare needs, and the effect of minority stress on health among lesbian, gay, bisexual, and transgender individuals. So all of these areas so important to what we're doing here today. Dr. Livingston, thank you for joining us today and to tell us about the vet chain too, but also this incredibly important area that you lead that's so important to our veterans. Dr. Livingston.
Thank you very much for that introduction. And I apologize in advance. My voice is a bit hoarse from a cold I'm getting over. And thank you, Dr. Clark, for teaching me something and also setting me up nicely to follow that act. You know, it would be great if we could say, or even I could estimate with any degree of confidence that we're going to solve the issue of alcohol use disorder in the next few decades. But I think that's unrealistic. And in the meantime, varied and innovative tools to expand the reach and access to these individuals who might benefit from treatment, I think, are vital. So it is great to hear about other things that folks are doing outside of my circles to move the needle for these veterans. But today, what I'll be talking about with you all, or at least for the next few minutes, is Vet Change, which is a web-based intervention that we developed to help veterans take charge of their drinking, as well as their post-traumatic stress disorder symptoms that are impacting their drinking. Next slide. Thank you. So before presenting Vet Change, I just want to share briefly some of the context that motivated the need for this intervention in the first place. As others have made the case already, I'll just review briefly that rates of hazardous substance use are higher among veterans, and the prevalence of co-occurring PTSD is very high among veterans who engage in hazardous drinking. And in fact, the issue of alcohol use extends beyond the prevalence. In fact, data that we've just recently analyzed is that among veterans who drink, the average loss of life in terms of total years is about 20 for veterans who drink. And that's 16 years of average life lost due to chronic conditions as a result of drinking. And even higher than that, acute causes of alcohol attributable death are associated with an average loss of 26 years per life. And so this is, I mean, those are real numbers and those are real years, and this is a significant problem. And so early detection and intervention can help offset those, of course. And, you know, just to underscore even further my appreciation for this platform to discuss these concerns. But it's also true that in the presence of PTSD, this can significantly and negatively impact a person's ability to reduce or quit their drinking. And that's because drinking is actually very effective in helping people to manage symptoms of PTSD. The downside is that it's just not effective long-term and has its own consequences. So despite the fact that web-based and app-based interventions exist to help people manage their drinking, none have actually existed until Vet Change that actually addressed the co-occurrence, which we saw as a critical service gap for these folks. But another motivating factor is that there are considerable barriers, as folks have mentioned, to receiving care for substance use and PTSD. And we believe that, and so do others, that technology-based interventions can help address treatment need while also circumventing some of the typical barriers to care. Next slide. And so Vet Change then is a self-guided, self-help, web-based intervention. So getting started with this intervention is as simple as clicking the Get Started icon, so the lower arrow, or if you're a return user, hitting the login button and logging into your account. Next slide. Thank you. Vet Change is a publicly available website designed for veterans who are interested in cutting back or quitting their drinking altogether. It is a flexible intervention that allows the users to choose their own goals and pick and choose from the available therapy content to work toward them. And while it is a web-based intervention, it is also compatible with tablets and smartphone displays, so that veterans can use it on the go 24 hours a day, and ideally in situations when they need it the most, which are in those high trigger, high craving situations where maybe other supports might not be readily available. Next slide. My voice is holding up. We'll see if we can make it the rest of the talk. So several of the key features with Vet Change, which are immediately available after the 30-second registration process, include alcohol assessment and normative feedback that Dr. Clark mentioned, which is itself a brief evidence-based brief intervention. Vet Change also includes other skills-focused modules, resources, and customizable features such as email and text message support and daily tips that can be turned on or off. I mean, the truth is that some people really appreciate the banner notifications reminders, others find them obnoxious, so that is customizable. Next slide. And so this is a screenshot of the alcohol screening and normative feedback page in Vet Change, which veterans are guided through during the registration process. So this veteran here provided the number of days per week that he drinks and the number of drinks that he typically consumes per day. And the feedback that he received includes his total drinking for the average week, but also how his drinking compares to the population based on his gender and his age. And so as shown here, this veteran consumes an average of 35 drinks per week and is drinking as much or more than 95% of similarly aged men in the United States. And this is an important intervention because it helps to highlight some of the discrepancies, because often people who drink are also surrounded by people who drink, and so they might perceive their drinking as normative when in fact it could be life-threatening. Next slide. Thank you. And after this, the veteran is asked about the consequences of their drinking and given feedback about that. And they're also asked about their trauma and deployment stressors and PTSD symptoms that might be impacting their drinking, and then given feedback about ways in which it could be impacting their drinking and recovery. Next slide. And then once finished with this portion, veterans have free and open access to all of the features of the site. And one important feature includes the daily substance use log. And it used to be the drink log, but now we've included other drugs to be responsive to the changing needs of this population, and the fact that illicit and prescription drug misuse rates are certainly on the rise as well. And in this image, you can see up top inside the red box there that in my hypothetical scenario here, my goal is to drink 9 drinks per week, or no more than 9 drinks per week, and 3 or less per day. And you can see my detailed tracking results from the week as well, just beneath that. So as you can see there, I didn't record anything on Monday. I drank 3 drinks on Tuesday, and I drank 1 drink today, and also used heroin on, well, actually I drank 1 drink Wednesday and then used heroin on Wednesday as well. And if you look to the right here in the last box, that's my report for Wednesday, or we'll just say today. My number of drinks is 1. My urges to use were strong. I also used heroin/fentanyl. My mood was angry. And then I can describe the situation to provide a little bit more context for my own tracking purposes, so that people can start to gather some data on themselves to increase levels of self-awareness and hopefully get a handle on these things. Because oftentimes triggers are known, but also many times they are not. And it's helpful to get some of that clarity as people progress. Next slide. beneath my daily tracking, the screen that I just showed you, are the different modules that we can choose from, that I have access to. And so I've completed the first one here when I registered, and that's the learning about yourself, the alcohol screening and PTSD impacts surveys. And actually, let's go to the next slide. Thank you. Next, I can participate in the motivational enhancement material to further increase my motivation if necessary. And this is where I identify my personal reasons for changing versus not changing my alcohol use. And then then with that information, I can make an informed decision about whether or not it's time for me to change. But really, the goal of this is to help people to see where they fall in the hopes of moving the needle further with respect to their motivation to actually make that change. Next slide. And then next is a very popular module, which is the goal setting one. And this is the one that allows veterans to set alcohol moderation or abstinence goals. These goals are then superimposed, as I already showed you, on top of a daily drink log, so that you're always tracking your daily use with the goals that you've set for yourself, and you're given notice if you exceed that. You can also see that visually. And the important point I'll make here too is that while abstinence is a desired goal for many people, especially from a clinical perspective, the truth is that there's good data to support enhanced quality of life and in health outcomes with even moderate drinking. And I'll talk a little bit more about that in just a moment. Next slide. In the next row down are the skills focus modules, which help the veterans to manage high risk, well, identify and also manage high risk situations that are personal to them, and manage difficult feelings and moods, and develop sober social supports, and then importantly, manage urges to drink. You know, we have all of these different tools, but the truth is that every substance use boils down to an urge, and the degree to which the person manages it could determine whether they use or not in that situation. So that's a new module that we recently built, and it's been become a favorite. Next slide. Thank you. And then the last row here, veterans can receive support and guidance around managing sleep, stress, and anger more effectively, and importantly, without using substances to manage them. All right, next slide. So I'm not going to, the consensus is really that the vet change is feasible and acceptable to folks. And at this point, we've conducted 2 large-scale outcome studies and published it for reports documenting some of these findings that I'll share just very briefly in the next slide. Thank you. And I won't get into the specifics because there's a lot of information in any one article, and I've got a bunch here pasted. But I do want to spotlight that that a few publications demonstrate the effectiveness of vet change in a randomized clinical trial, and the fact that alcohol outcomes improved regardless of whether veterans chose moderation or abstinence drinking goals. So there really is benefit to anybody here, regardless of what they're hoping to accomplish with their drinking. You know, it's not designed to promote drinking. So if they're coming there for that, then obviously this isn't the app or platform for them. But if their goal is to cut it down or stop, they can derive benefit. But this was also true for individuals with the highest level of PTSD, which was a concern that maybe this works for folks with a certain level, mild, maybe moderate, perhaps, but not severe. And the truth is that those with more severe PTSD symptoms benefited most. There was even evidence that these individuals, well, like I said, did better. Next slide. Thank you. And I also want to highlight too that in a separate study, we demonstrated the nationwide reach of vet change. And importantly, about half of these individuals that we reached in this study were not engaged in mental health treatment beyond this intervention. So when I say reach, I mean we were really reaching people who were drinking at hazardous levels and who were eligible for care, but were not receiving it and hadn't received it recently. Which again, I think speaks to the unmet need and leveraging technology to expand the reach to those when other barriers might make it impossible for them to receive that intervention. Okay, next slide. Build in plenty of time here for questions. But as I said before, VetChange is available for anyone to use, and it is free and secure. And all folks need to do is log in or create an account at www.vetchange.org. And when I say free, I mean just that. There are no paywalls, there are no trials. It is something that is operated with support from funders, et cetera, so that we can maintain a public-facing self-help intervention for those who could use the support. And in the last slide here, which is on the next slide, I just want to briefly acknowledge our team here, and then look forward to any questions at the end. Thank you.
Well, thank you, Dr. Livingston. That's a terrific initiative, unbelievable support. What an impressive group that's focused on helping our veterans. We're now going to hear from Tom Porter, the Executive Vice President of Government Affairs at the Iraq and Afghanistan Veterans of America. Tom joined IAVA in 2015 and now leads its government affairs team. He advocates for our nation's veterans, and he also serves as the spokesman for IAVA priorities. He served 9 years on the staff of 3 senior members of Congress. He's a captain in the Navy Reserve with service since '96, including deployments to Afghanistan and the Arabian Gulf. He's going to talk to us today about IAVA, its mission, what he sees among the veterans from Iraq and Afghanistan, and talk a little bit about alcohol use disorders and mental health disorders. And I want to say, as a Vietnam veteran, I am so respectful and admire of what Tom and his colleagues have done for the Iraq and Afghanistan veterans, and what they've done to pressure our Congress and our Veterans Administration to do things they otherwise would not have done. And I wish that there'd been organizations like this when we were fighting the Agent Orange issues back in the 70s and early 80s. But Tom and his colleagues have really, and the vast bulk of our veterans today are the younger veterans. And so, Tom, we really, as Dr. Clark is nodding his head in approval, Tom, you all are doing just such important work. Over to you.
Thank you, sir, and I appreciate the plug. Also, great appreciation to responsibility.org for hosting this event, and thank you for all of you on the panel for your contributions. Appreciate it. As General Panaro said, I work for IAVA. IAVA is the largest national veterans organization that focuses mostly on the post 9/11 generation. Although we do include veterans from other generations, we focus on most of our energies on the post 9/11 generation. We do some main things. We empower the generation. We advocate for veterans, and we provide peer-to-peer support. On the first one, in normal times, we normally fly in throughout the year, many veterans to Washington, D.C. We train them how to tell their own personal stories of service and how to advocate for themselves and their community. And then that feeds into our national advocacy efforts. So we're very aggressive on Capitol Hill and with the administration. Top priorities are gaining benefits for veterans and service members who've been exposed to burn pits and other toxic exposures, filling gaps in care for women veterans at the VA and DOD, protecting the GI Bill from cuts and abuse, reducing the stigma for medicinal cannabis use, addressing military sexual assault, and then a top issue that's always a top focus of our membership is mental health and suicide, is combating the suicide crisis that we've already heard a little bit about already in this. But then more specific to this meeting is a lot of the stressors that we know that veterans experience that drive mental health and substance abuse problems and challenges. And so a lot of those that we know can be better prepared for in advance, like ensuring we address transition issues when they leave the military and enter the veteran community, like making sure that they have access and that they use their education benefits, like the post 9/11 GI Bill that we helped to fight for, addressing homelessness, creating jobs, or creating the right circumstances to improve their job earning capacity. Also ensuring that VA works for all veterans, including women veterans. And women, as you all know, women are the fastest growing cohort in the military and veteran communities. We need to make sure that the VA works with women veterans, and there have been great strides, but more needs to be done. But then others aren't as predictable as we know from the last year, like all of the upheaval during the COVID pandemic and a lot of the uncertainty within the veteran and military community, life or death concerns. Also, during the month of August and still today, we're dealing with a great deal of anxiety and stressors resulting from the Afghanistan withdrawal. And that's something that we actually surveyed our members directly about. Our survey that's about to be released in the coming weeks just closed, but I can say preliminary data shows that the percentage of our membership that say our effort in Afghanistan was worth it. 2 years ago, 62% said it was. In August, 52% said it was. So that took a 10% dive. So you have a lot of veterans and their families questioning whether or not their service was worth it, especially in Afghanistan. Also, what hasn't been reported yet, and again, this is preliminary data, is that 63% of our membership said they supported removing our troops from Afghanistan. However, 68% disagreed with how the president withdrew our troops from Afghanistan. And an even larger number, 85%, said we should have done a lot more to evacuate our Afghan allies. So those are some major stressors in our community right now. And we encourage all veterans and service members to seek help when needed. We have specifically for not just our membership, but all veterans, service members, and family members, is called our Quick Reaction Force. That's our peer-to-peer support. It's free. It's 24/7 access. Again, it's a Quick Reaction Force, and you access that at quickreactionforce.org. That's quickreactionforce.org, and that's 24/7 peer-to-peer free support for emergency financial assistance, for homelessness, and mental health, among other things. And so we encourage all veterans to check in with us, check in with each other, and encourage any veteran or service member or family member to seek support when they need that. So those are the top priorities that we're working on. Happy to answer any questions.
Well, Tom, thank you so much. And I think that survey is so important and underscores a lot of key issues. And I know, because as a Vietnam veteran, I get asked the question all the time, was Vietnam worth it? What about the Marines that served with you? And I say, look, it's not an issue of whether we should have been there or not. It's not an issue of how the Vietnam War ended. What I can say to the families, what I can say to those Marines and everybody served, they did everything their country asked of them and more. The folks that served in Afghanistan, they did everything their country asked of them and more. They aren't responsible for how we left Afghanistan and the policy decisions made by various administrations. Their service is respected and revered, and organizations like yours and Dr. Clark and Dr. Livingston are reinforcing this every day. So I hope that that survey will encourage, members of Congress and the media to thank these veterans and make sure they understand their service is appreciated, and they don't bear any responsibility for decisions that are made at the political level. And so, Tom, I know you know that, and I know our colleagues know that. Let me see if Brandy or whoever thinks there's any questions from the audience. And if not, I've got a couple I might pose to our group. So are there questions from the audience?
I think we've answered a few in the chat, but now is a good time. If you have any questions, go ahead and put them into the Q&A box. And General Cunaro, maybe you can start off with a couple of yours, and then we can do, I see we are getting a couple of questions in. So why don't you go ahead and ask a couple of yours, and then we'll come back to the audience.
Well, I would think I've asked all three of our colleagues, and again, I think you see how expert they are and how they've dedicated their entire life to this area. What are some of the ways that all of us, and particularly the people on this call, whether you're a clinician or you're a veteran or you're in government, what are some of the ways to remove the barriers to veterans accessing treatment? Because I think you hear it all the time. There was a news, CBS News or one of the national news had just a heartbreaking story last night about a Navy SEAL that would not go get help because he thought it would wreck his career. And his wife had to watch him with a gun to his head. He committed suicide. What can we do to remove the barriers to veterans accessing treatment? Dr. Clark, why don't we start with you, then go to Nick, and then go to Tom?
We start off with respect for the veterans who's done all that our society has asked them to do. I like the way you frame that. And we have to separate policy from the individual who commits himself in the service of the country. And we need armed forces. And when we've got individuals who are willing to essentially put their lives on hold in the service of the rest of us, we need to start respecting that. And with that attitude of respect for the person who's done what we've asked them to do, we can communicate the idea that we know that consequences happen, and you did what we asked you to do, and we're here for you. And clinicians need to understand that. So we cannot allow policy and politics to contaminate our interactions with our veterans. They stepped up, we need to step up. And if we've got problems with policies, we take it up with the politicians and not with the veteran. And the clinical context can't just focus on blaming the veterans for the policy. That's terrible. So I think we start with that. And as we've been pointing out, both Nick and I, making sure that at the community level, people are asking questions who are clinicians, who are in the faith community. Someone pointed out in the comments that peers don't do assessments, but peers do interact. They actually do assessments. They don't diagnose per se, but they could help facilitate getting awareness on the part of the veteran who's troubled by using either the CARS tool or the vet change tool, so that the vet knows that people are aware that he or she is going through things. And we can't just dismiss that, because what that says is we don't really care, and we must care, because in times of need, those people who step into the breach are the ones we have to support.
Amen. Hallelujah. Nick.
Yeah, I second all of that, and this is not a simple solution. Well, maybe it is a simple solution, but it's not an easy one. But the culture around what psychiatric distress means and the stigma around it, and the culture of how we respond to those things is a significant barrier. I mean, a lot of the veterans that I work with are folks who are trained to do combat, trained to be military service members, but not trained to talk about the impacts. In fact, trained more so and more likely to not talk about those things. And so usually when we see patients in VA, the disorder has progressed to a degree that the consequences are very apparent. And what we know from years of public health research and clinical research is that prevention is always the most effective thing, but we can't engage in prevention very effectively if folks don't feel comfortable talking about those sorts of things. So that's at more of a broad macro level thing and a culture shift that I do think is important, and policy does have impact on that. And so that's one suggestion I have. And the other is to continue to think creatively about who are these people that we are reaching and who are using these services, and who are the people that aren't, and what are the creative ways in which we can engage those folks. I mean, using phones and technology is an organic thing for some, but the truth is that there's some who won't receive care and won't use a smartphone app or a website. So how do we reach those people? And I think we just need to continue to think in innovative and creative ways about who's got unmet need and what can we do about it. And I know it's a little bit hard to get funding for those sorts of initiatives, because at some point people argue like we need to fund things that provide the greatest good to the greatest number. But the truth is that these disparities end up costing a lot more money. And when disorder gets severe, and these are folks who end up in our hospitals and rehospitalized, repeat detoxes and things like that, those costs add up. Not to mention these are human lives. So I think there's an economic argument and a humanistic one to be made for continuing to identify where the unmet need is and targeting intervention and prevention at those people specifically.
Great insights. Tom, I know you deal with this every day. What are your thoughts?
Well, thanks. I first wanted to answer one thing that you said before. I appreciate you mentioning that veterans shouldn't feel they need to be responsible for political decisions. that are outside of their control on these past 20 years. I think adding on to that, veterans need to consider, did they serve with honor? Did they support the men and the women in the front and the back, the left and the right of them while they're deployed? Did they defend the Constitution? And also the public should be mindful that everybody that's served over the last 20 years has volunteered to serve knowing they were going to go to war, probably. And that's very unusual throughout our whole history. And that those people that are serving throughout the last 20 years volunteered to do this. And so they deserve an enormous amount of credit and gratitude. So I appreciate that. Adding on to what our current topic is about the transitions, a lot can be done in terms of VA outreach because a lot of veterans aren't within the VA system. And when we're talking about the top concern of ours here is mental health and suicide, we supported a major omnibus legislation that passed into law just under a year ago called the Commander John Scott Hannon Act that is the most comprehensive suicide prevention legislation ever passed. And so the centerpiece of that is outreach. It creates a new grant program from the VA to community groups that specialize in reaching and treating veterans' mental health and suicide issues. That's being implemented now. So that is a major effort that is underway soon in terms of outreach. Also, your vet centers that are out in the communities. They're the face of the VA where the VA major facilities aren't. So we encourage them to reach out to the communities, but then also veterans to reach out to them. Those are some new benefits. And also the VA should be more welcoming to all veterans. So I know especially women veterans often will tell us that they don't feel welcome in the VA that's close to their home. And so that's why we are asking the VA to take extra effort to make sure that they have a welcoming facility and culture that's inviting to all veterans. And then just to overall reduce bureaucracy and make it easier for veterans to get in the system, because polls show that once veterans are in the VA system, they appreciate and like the care. So those are some of the things that we can do to reduce challenges with transitions from military to veteran community.
General, I would
Thank
also
you.
like to
Go ahead,
suggest
Dr. Clark.
that we need to work with the DoD in terms of addressing the expectations of veterans who have been subjected to trauma. That messaging has to start at the DoD, and I know they're busy, but the handoff and the communication between the clinical community and the civilian sector and the DoD needs to be enhanced so that we just don't drop people through holes in the safety net.
Amen. They talk a good game there, but there's a lot of improvement that's needed there. Brandy, maybe we have time to take one from the audience. What do you have there?
We have two, and I'd love to take. I'd love to do them real quickly, and then we can call it to a close. The first one is, what role in primary care physicians or emergency doctors or urgent care centers? I know that it's been said in the past that they don't necessarily have the treatment resources to refer people to right away. So a question has come up regarding medication-assisted treatment. Can that provide a bridge while they're getting connected to veterans treatment facilities? If you could address that one. And then after that, the other question is around spouses and significant others. What role can they play to get involved in the treatment programs?
So let's approach it this way. Let's let our two doctors start with the first question, and then I'm going to ask Tom, because he works with these people every day, to take the lead and talk about what spouses and significant others can do. So Dr. Clark, start with you on the first question.
We can start that process with the two tools that we've been discussing. The referrals can be facilitated, and there are medications for alcohol, there are medications for opioids. There are no medications for stimulants and for marijuana or hallucinogens, but there are medications for alcohol and for opioids. and we can use, if it's appropriate, we can start with that. And SBIRT can be tied to, or screening, brief intervention, and referral to treatment can be tied to initiation of medications. And we know there are a number of emergency room settings where that is actually happening. So we just need to generalize that practice if that's where the veteran presents.
Nick?
Yeah, I would agree with that. One thing I'll say too is I'm always mindful of, you know, the different clinical reminders that primary care and emergency staff have, and alcohol use is a very important thing to screen for. But if that's not the reason they came in, it can be easy to not ask the questions. The truth is, a lot of these providers don't have the training to do those things either, which is, you know, fair enough. So I think one thing that we could think about that could support those efforts is to create automated services and things to help with that. You know, I didn't talk about it today, but we've automated a relational agent called Vora who does brief screening and intervention. And the effectiveness is similar to that of a provider, but the rates of referral are 100%, whereas rates of referral among providers, given a positive alcohol screen, were about 23%. And that's not a slam on humans. It's just that humans are human and robots are, well, more reliable and when they're programmed to do very specific things. So that's, again, just speaks to some of the ways that we might build services that help to bridge those gaps, those service gaps, while not demanding more of providers who are already called on to do a lot. They're very busy.
Okay, and Tom, for you to answer the last question that I know, I mean, I recall with my brother Anthony, my parents, certainly I had no idea how to deal with his situation. The VA had no idea how to deal with the situation. Our local doctors, you know, because when we saw he wasn't getting help from the VA, they had no clue. You know, and the lady that was on last night about her husband, the SEAL that killed himself, the reason she went on, because she wants to basically try to help others figure out how they can help people in this particular situation so they don't have to go through what she went through. But Tom, I know you deal with us all the time. What is your advice here?
Well, first, like I said before, reach out for help. And if you're a spouse, significant other, or family member, take extra care to recognize if your veteran or service member, family member is in need of help, and ask them about it. And then ask them to seek help. Again, we've got 24/7 peer-to-peer help for all veterans, family members, regardless whether or not they're a IA VA member or not. Again, they go to quickreactionforce.org and seek help. And one of the key things we do is provide referrals to mental health resources. And then there's also, as you know, but the public may not, but it's important to know that the VA has the crisis hotline. That's available for people in mental health crisis as well. That number is 800-273-8255. That's 800-273-8255, and veterans press 1 for help. And so the Veterans Crisis Line, you can just Google that too, and probably that's easier. So those are two big resources, but overall, I can't encourage it enough for family members and other veterans to tell them it's okay to seek help, and then encourage them to do that.
Well, thank you. And thank our 3 experts, Dr. Clark, Dr. Livingston, Tom Porter. Thank responsibility.org for helping organize this and support these important programs. There's nothing more important that we can do than support the troops that have fought for our freedoms and our democracy. So to everybody on the call, thank you for joining us today. For the Marines, happy Marine Corps birthday, and tomorrow, Veterans Day. Let's remember those who've served and continue to serve. And again, thank our 3 expert panelists who've dedicated their lives to helping our fellow veterans. So thank you all very much, and have a good day.
Thank you.
Thank you very much.
Thank you.